Hello friends, now we are going to see the traumatic brain injury guidelines. So the traumatic brain injury is primarily divided into the primary brain injury and secondary brain injury. Primary brain injury include disruption of the brain vessel, hemorrhagic contusion, diffuse axonal injury, hematoma, and secondary brain injury includes hypoxemia, hypotension, hypocarbia, hyperthermia, hypoglycemia, hyponatremia. Then it may occur because of the intracranial secondary events like raised intracranial pressure, vasospasm, seizure, and infection. So we'll see what is tier 0 treatment. If somebody presented with us with severe traumatic brain injury with the GCA score of 3 to 8. So expected interventions are admission to the ICU, endotracheal intubation, mechanical ventilation, serial evaluation of neurological status, pupillary reactivity, then the elevation of head end of the bed to 30 degree to 45 degree, analgesia to manage the signs of the pain, sedation to prevent agitation, ventilatory asynchrony, and temperature management to prevent fever. Then recommended interventions are insertion of central line, end-tidal CO2 monitoring, consider anti-seizure medication, maintain cerebral perfusion pressure more than or equal to 60, maintain HP of more than 7, avoid hyponatremia, optimize venous return, arterial line continuous blood pressure monitoring, and maintain the saturation more than 90. Then standard ICU monitoring include wide pore orogastric tube, temperature monitoring, ICP plus brain tissue oxygen monitoring, and bispectral index monitoring to ensure adequate sedation. Then ICP should be monitored in all salvageable patients with severe traumatic brain injury and abnormal CT scan. Abnormal CT scan of the head is one that reveal hematoma, contusion, swelling, herniation, and compressed system. So ICP monitoring is indicated in severe traumatic brain injury with normal CT scan if two or more of the following features are noted at admission, like age over 40 years, unilateral or bilateral motor posturing, systolic blood pressure less than 90. When calculating cerebral perfusion pressure in traumatic brain injury, MAP should be the mean cerebral arterial pressure estimated to exist at the level of middle cranial fossa, which can be approximated by positioning the arterial transducer at the tragus of the ear. The arterial transducer must be repositioned to remain level with the tragus following changes in the body elevation or position. So regarding brain tissue oxygenation monitoring, follows separate brain tissue oxygenation monitoring strategy. Cardiac output monitoring to be considered if no response to crystalloid and no response to 0.1 microgram per kg per minute of noradrenaline. Then if acute and pre-existing cardiac disease, in systemic sepsis, if cardiac contusion known or suspected, if pulmonary edema develops. Then peripheral nerve stimulator if administering muscle relaxant. Consider EEG if we are suspecting a seizure or during barbiturate coma. Troponin if specific investigation that we need to be considered the troponin in case of chest trauma and if age is more than 50. Then triglyceride level as baseline. Then creatine kinase and consider urine and serum osmolality. Regarding cervical spine, clear the cervical spine if possible. If hard collar is required, change to the aspen. This is likely to cause, because this is likely to cause ulceration. If injury is detected, then management of detected injury must involve consultant neurosurgeon. It's strongly recommended that thoracolumbar spine of unconscious patient should be cleared within 48 to 72 hours. Because beyond this time, the morbidity and mortality of spinal precaution probably exit the risk of missed spinal injury. So this initial regarding our initial goal, a patient should be fully sedated. Analgesic and paralysis is required. Now, regarding ventilation, follow lung protective ventilation, like target PO2 of more than 90, PCO2 of approximately normocarbia. Avoid routinely decreasing PO2 level of less than 40 x less than 30 mmHg if critical situation when hyperventilation must be needed to buy time. So a decision to reduce the PaCO2 to less than 4 kPa must be made by consultant intensivist, neurosurgeon, and ideally with brain tissue oxygenation monitoring in situ. Consider early evacuation of space occupying lesion. Then we have to optimize the cerebral perfusion. Cerebral perfusion should be more than 60 mmHg and ICP should be less than 22. Brain oxygenation level should be more than 20 mmHg. Consider CSF drainage to manage intracranial hypertension. Measure core temperature and avoid a high temperature of more than 38 degrees Celsius. Optimize hemodynamic and volume status. Prophylactic antiepileptic for 1 week. Establish early enteral feeding within 24 hours if possible. Blood sugar level should be optimized, that should be between 140 to 180. Treat established and clinically significant infection. If mild to moderate traumatic brain injury and within 3 hours, give tranexamic acid and then bolus of tranexamic acid over 8 hours. Initially, 1 gram tranexamic acid should be given, then then infusion. Now, this is the tier 1, tier 2, tier 3 management of traumatic brain injury. We'll see one by one. Tier 1 includes maintaining cerebral perfusion pressure between 60 to 70, analgesia and sedation to lower ICP, maintain PaCO2 between 35 to 38, then mannitol by intermittent boluses in the dose of 0.25 to 1 gram per kg, hypertonic saline by intermittent bolus, CSF drainage. If IVD in situ, consider placement of EVD to drain CSF. Consider anti-seizure prophylaxis for 1 week only. Consider EEG monitor. Then tier 2 consists of mild hypocapnia in the range of 32 to 35. Neuromuscular paralysis, if adequately sedated patient, is efficacious. Perform a MAP challenge to assess cerebral autoregulation and guide MAP and CPP goal in individual patient. It should be performed under direct supervision of physician who can assess the response and ensure safety. No other therapeutic adjustment should be performed during MAP challenge. Initiate and titrate vasopressor and inotrope to increase the MAP by 10 mmHg for no more than 20 minutes. Monitor and record the key parameters like MAP, CPP, ICP, and brain oxygenation before, during, and after challenge. Then adjust the vasopressor inotrope dose based on study finding. Rate CPP with fluid bolus, vasopressor, and inotrope to lower ICP when autoregulation fails. Then tier 3 recommendation includes pentobarbital, thiopantol coma, secondary decompressive surgery, and the mild hypothermia. Now, the ICP guided management of severe TBI, traumatic brain injury. The detailed flowchart is as follow. If ICP is more than 22 mmHg, then tier 1 follows the sedation analgesia, CPP 60 to 70, PCO2 between 35 to 32 to 35 mmHg. Consider osmotherapy, consider EVD. Then tire moves to directly tier 3 targets are not met. If parameters are And then for if ICP is not controlled, then follows the tier 2. Then in tier 2, recommended neuromuscular blockage. Then in tier, if still ICP is not controlled, and if with tier 2 parameters are stable for 4 hours, then de-escalate care, reduces the CPP to baseline values and assess. And if it is and if there is no recommendation, no improvement, then move to tier 3. Tier 3 include consider raising CPP if map challenge is successful. Consider barbiturate coma, then surgical decompression, mild hypothermia, and targeted ventilator to achieve PCO2 between 32 to 35. Recommendation: re-examine the patient, consider repeat CT, consider the surgical option for potential surgical lesion, consider the extracranial elevation, and review the basic physiological parameter. Consider consultation with higher level and the care. Regarding optimal map challenge, perform under direct supervision who can assess, and as no other therapeutic adjustment should be performed during MAP challenge. Initiate and titrate vasopressor inotrope to increase MAP by 10 mmHg for no more than 20 minutes. Then monitor and record key parameters like MAP, CPP, ICP before, during, and after challenge. If ICP improves with challenge, consider higher CPP range. If there is no improvement, then return the vasopressor inotrope dose to pretest dose upon completion. Now, management of the severe traumatic brain injury by intracranial pressure and brain tissue oxygenation. If the brain tissue oxygenation is more, so according to this, they have divided the patient into 4 types. That is type A, type B, type C, type D. Type A include brain tissue oxygenation more than 20 and ICP less than 22. Type B include brain tissue oxygenation more than 20 and ICP more than 22. Type C include brain tissue oxygenation less than 20 and ICP also less than 20. And type D include brain tissue oxygenation less than 20, ICP more than 22. So we'll see if brain tissue oxygenation is more than 20, is also raised, then how to manage. So first consider sedation, analgesia, cerebral perfusion pressure between 60 to 70, maintain PaCO2 between 32 to 35, consider osmotherapy and consider the EVD. Then type 2 include type 2 tier include recommended neuromuscular blockage. Consider targeting ventilator to achieve PaCO2 between 32 to 35. Then type 3 include consider raising CPP if map challenge is successful. Then consider barbiturate coma, surgical decompression, and mild hypothermia. If brain tissue oxygenation is less than 20 and ICP is also less than 22, then the following measures that we need to follow, like assess sedation analgesia. CPP should be between 60 to 70, PaCO2 between 32 to 35, and maintain the adequate oxygenation level. Then tier 2 include increase CPP to 70 to 80, increase PaO2 to more than 90, recommended neuromuscular blockage, reduce ICP to less than 22, transfusion of RBC to HB of more than to maintain the HB of more than 9. Then consider titrating ventilator to maintain PCO2 of 32 to 35. Stop if ICP more than 20. Consider raising CPP if MAP challenge is successful. Consider titrating ventilator to maintain CO2 between 32 to 35. If brain tissue oxygenation is less than 20 and if ICP is more than 22, then the same, but we need to maintain the normal oxygenation level. Other measures are same in tier 1, that is assess for sedation analgesia, ensure the cerebral perfusion pressure between 60 to 70, PCO2 between 35 to 32 to 35, maintain proper oxygenation, consider EVD and train CSF in EVD in situ. Then tier 2 include increase CPP to 70 to 80, increase PO2 to then recommended neuromuscular blockage, transfusion of the RBC to HB more than 9. Then tier 3 include consider raising CPP if MAP challenge is successful, consider barbiturate coma, consider surgical decompression, and consider PO2 of more than 20. So during inter-tier recommendation, re-examine the patient, consider repeat CT to evaluate intracranial pathology, consider surgical option, consider extracranial cause of ICP elevation, review basic physiological parameter that are in desired ranges. Then regarding ventilation, ventilate using volume control mode, use ERDS net ventilation guidelines to ventilate the patient. Ensure that tidal volume and minute volume are constant. Variation in ventilation will result in CO2 fluctuation and episodic rising ICP. The fluctuation can have significant detrimental effect on cerebral blood flow. So set the alarm limit for minimum volume. For minimum volume close to desired target and to detect varying minute volume due to changes in respiratory compliance. When adjusting ventilation, only small changes should be made and time allowed for this to take effect. Measure blood gases every 15 to 20 minutes after all changes in ventilatory setting and record response to change. So maintain the oxygenation, appropriate oxygenation level. Oxygenation should be more than 90, where PCO2 level should be 32 to 35. Mild hyperventilation to reduce PCO2 level should be depending on the brain tissue oxygenation monitoring. Avoid reducing PCO2 level below 25 mmHg, except in the critical care situation, which may be needed in emergency to buy a time. On transfer to CT scan, use ETCO2 and ICP block from the patient bedside monitor in transport monitor. Then respiratory failure is common after traumatic brain injury and occurs secondary to direct pulmonary injury, aspiration, neurogenic pulmonary edema. Neurogenic pulmonary edema occurs in the absence of underlying heart and lung dysfunction and may occur within minutes to hours of injury, and it may have delayed onset. It is believed to be caused by a massive sympathetic discharge with resultant systemic and pulmonary hypertension. This leads to increased pulmonary capillary pressure and edema. Centrally induced increase in capillary permeability also be present. Symptom usually resolve in 24 to 72 hours. Treatment is supportive and it should therefore activities associated with patient when diagnosed pulmonary edema such as suctioning, turning the patient should be done. Then the next is the how to manage the cerebral perfusion. So an increased CPP can lower ICP if autoregulation is entered. Constriction, reducing this is if autoregulation is reducing cerebral blood volume. If autoregulation is disrupted and increased CPP may worsen ICP by increasing cerebral blood volume. A MAP challenges to assess autoregulation should therefore be performed by practitioners capable of interpreting the result. If MAP challenge is successful, benefit should be weighted against the risk of pharmacological MAP augmentation. Regarding sedation and analgesia, initial choice propofol and fentanyl. So propofol should be used in the range of 2 to 4 mg per kg per hour and maximum 400 mg per hour. Monitor the signs for propofol infusion syndrome. Propofol is contraindicated for sedation of ventilated children. Propofol should only be given in the short term and for no longer than 24 hours. Caution should be used when administering propofol to patients who are 17 to 18 years of age. Fentanyl 1 to 6 microgram per kg per hour, maximum 600 microgram per hour. Prior to increasing fentanyl dose, consider using test bolus of 25 microgram to see the impact on IC. Propofol bolus of 10 to 20 mg can be considered to allow nursing, medical, physiotherapy intervention if required, but be aware of the potential hypotensive effect. Then be aware of opioid withdrawal. Ensure adequate analgesia and, if necessary, increase midazolam rather than opioid to manage intracranial pressure. Tachyphylaxis is extremely common with morphine infusion, leading to possible need for dose de-escalation and prolonged period of withdrawal when therapy is discontinued. Tachyphylaxis and withdrawal syndrome symptoms may also occur after prolonged use of fentanyl. Use scoring system. Use the sedation scoring and in acute phase aim for no eye opening, no limb movement, no spontaneous cough, no suctioning, and no respiratory effort. Maintain the bispectral index score between 20 to 30 initially. Consider a neuromuscular blockage. Neuromuscular blockage is prior to intervention. If trial dose is effective in lowering ICP, then infusion can be considered, but this should be reviewed on regular basis and discontinued if needed. Now, regarding propofol infusion syndrome, this is early markers are unexplained metabolic acidosis, elevated serum lactate, creatinine kinase, myoglobin, hyperlipidemia, triglyceride. Common clinical features are metabolic acidosis, cardiac arrhythmias, especially bradycardia. Early sign is RBB with concave ST elevation in the right precordial lead. Brugada-like changes, cases of LBP have been seen. Then hyperkalemia, rhabdomyolysis, hyperlipidemia, hepatomegaly, renal failure, and rapidly progressive cardiac failure is common, uh, which is unresponsive to iron. Predisposing factors are younger age, severe head injury, severe critical illness of central nervous system or respiratory origin. Then high dose exogenous catecholamine, steroid administration, inadequate carbohydrate intake, and subclinical mitochondrial disease, sepsis. So neuromuscular blockage, it should be considered if ICP remains high despite the use of the tier 1 measure. So bispectral index monitor may be in place to ensure patient have adequate analgesia and sedation prior to the administration of neuromuscular blockage. Neuromuscular blockage masks the neurological changes and potential seizure activity. It is also associated with longer intensive care unit stay due to an increased incidence of pneumonia. Therefore, the appropriateness of its use should be reviewed. Using C-cetraculium as per National Injectable Medicine Guide monograph. Administered initial bolus of C-cetraculium, that is 150 microgram per kg, followed by continuous infusion of 180 microgram per kg per hour to achieve 1 to 2 twitches using train of four test. Usual dose range of 30 to 600 microgram per kg per hour. A peripheral nerve stimulator must be used when administering neuromuscular blockage. So the use of this peripheral nerve stimulator minimizes the complication of prolonged paralysis by monitoring the degree of neuromuscular blockage. Then this management of cisatrapuram infusion using the peripheral nerve stimulation. If there is zero twitches, then reduce the infusion by 20% increment. If 1 to 2 twitches, maintain the present infusion stage. If 3 twitches, reload with the 75 microgram per kg and increase the infusion rate by 50%. If 4 twitches, then reload with 150 and increase the infusion rate by 100%. Now, regarding barbiturate, the high dose barbiturate administration may control ICP refractory to maximum standard medical and surgical treatment. It is associated with significant harm and it is in the tier 3 intervention. It must only be given following discussion with the consultant intensivist and neurosurgeon. Hemodynamic stability is essential before and during barbiturate therapy. So monitoring by the bispectral index during barbiturate coma therapy. The bispectral index value and the suppression ratio value have shown to correlate well with standard EEG-based method. Aim for bispectral index values of 10 to 20 and SR values of 60 to 80%. Hypokalemia has been reported commonly in patients receiving intervention. The fall in serum potassium is not due to increased urinary excretion of potassium. It is thought to be due to metabolic changes within the brain. Now, regarding steroid, the use of steroid is not recommended for improving outcome and reducing IC. In patients with the severe traumatic brain injury, high dose of methylprednisolone was associated with increased mortality and it is contraindicated. Approximately 15% to 20% of traumatic brain injury patients may develop chronic hypopituitarism, which clearly state that traumatic brain injury-induced hypopituitarism is frequent problem in contrast with the previous assumption. However, there is no epidemiological study showing the burden of disease in this population. Post-traumatic hypopituitarism is generally characterized by isolated anti-pituitary hormone deficiency rather than multiple hormone deficiency. Then the growth hormone deficiency seem to be the most common disorder. Current evidence implies that insufficiency in hypothalamic pituitary adrenal axis during acute phase after head trauma is associated with worse hemodynamic instability, relative and absolute hypoglycemia, hyponatremia, and rapidly progressive hypotension, all of which may increase the risk of morbidity and mortality. Interpretation of endocrine test in acutely ill patient is challenging and may lead to the overdiagnosis. So routine testing of pituitary function or measurement of serum plasma cortisol level in acute phase after TBI is not recommended. If there is clinical suspicion of cortical insufficiency, empirical treatment with hydrocortisone should begin immediately. So if there is, then patient should be discussed with endocrinology. Now, regarding intravenous fluid, the fluid input like 2.5 to 3 liter per 24 hour is the initial target. Maintain hydration with the early enteral feed. Supplement with IV sodium chloride or Hartmann if enteral feeding is not established. Avoid dextrose. Avoid hyponatremia. Treat hypovolemia with crystalloid and RBC. Maintain HB of more than 8. Normal or near normal clotting. Platelet count should be more than 1 lakh. INR should be less than 1.3 and FPTT should be less than 1. Urine output should be 0.5 to 1 ml per kg per hour. Urine specific gravity should be measured if output is in the excess of 250 ml per hour. Diabetes insipidus should be suspected if urine output is more than 250 ml per hour for more than 3 hours and specific gravity is less than 1.005. Confirm by measuring plasma and urine osmolality and electrolytes. In diabetes insipidus, plasma osmolality rises with marked rise in sodium of more than 150 and urine osmolality is very low and low electrolyte concentration. If confirmed on lab result, urine output continuing to rise and plasma sodium more than 155, consider the continuous dose of vasopressin. This should be discussed with consultant intensivist and neurosurgeon. Rapid reduction in sodium can be fatal. If sodium is less than 135, consider hypovolemic hyponatremia or SIH. Regarding decompressive craniotomy, the surgical removal of the portion of the skull may be performed to relieve elevated intracranial pressure. The first large randomized trial in 2011, DECRA trial, showed no benefit from bifrontal surgical decompressive craniotomy to reduce intracranial pressure, although the definition of refractory intracranial pressure elevation within 1 hour, that is more than 20 mmHg for 15 minutes, within 1 hour period was called. The subsequent rescue trial demonstrated better intracranial pressure control in surgical group and lower mortality, but high rates of vegetative state and severe disability in survival. So, in the view of this result, the decision to perform this procedure Most be a consultant decision which has involved the patient's surrogate, focusing on patient's previous stated wishes and personal values. Emphasis that life-saving procedure may not lead to return of normal function is important, and given the large proportion of survivor with poor outcome in surgical patients. Now, CSF fluid drainage. The EVD system zeroed at midbrain with continuous drainage of CSF may be considered to lower ICP burden more effectively than the intermittent use of CSF drainage to lower ICP in patients with initial GCS score of less than 6 during first 12 hours after injury may be considered. Now, regarding brain oxygenation monitoring, the LICOX brain oxygen monitoring system provides direct real-time measurement of partial pressure of oxygen in the brain tissue. It is unknown whether the use of brain oxygenation improves outcome, and this is being assessed by BOOST trial and BOSANA trial. Patient recruited to Bonanza may be randomized to ICP and brain oxygenation guided management. Its use may also be considered in any severe traumatic brain injury not recruited to Bonanza. A similar device is available from Raumedi. So FR2 is increased from 100% for up to 2 minutes, and brain oxygenation recording is monitored. This should result in increase in brain oxygenation by at least 5 mmHg. If the first challenge fails, the procedure should be repeated. If the brain oxygenation not increase as expected, the following should occur. If an arterial blood gas should be performed using FiO2 of 100 to ensure adequate systemic oxygenation. If this identifies significant problem with systemic oxygenation, this should be managed as appropriate by treating clinician. Often CT scan to determine if there is evidence of hemorrhage, contusion, expansion, and infection. Then the catheter can be replaced if second challenge fails or if CT scan indicate that probe is malpositioned. Ideally, probe should be replaced within the 2 hours. A completion of oxygen challenge, the inspired FR2 should be weaned back to baseline. For Bonanza control group participant, research staff will perform oxygen challenge to monitor reliability, but result will not be shared with clinician staff to maintain the blinding. Probe will not be replaced in control group and should the FR2 challenge fail. So for Bonanza participant, if the monitoring are accurate and more than 20 mmHg, the routine post-op CT should be obtained within 24 hours of device placement. So regarding temperature management, avoid hyperthermia. Hyperthermia following traumatic brain injury may be due to post-traumatic cerebral inflammation, direct hypothalamic damage, or secondary infection. If the patient has unexplained fever, they have sustained diffuse axonal injury and frontal injury, and there should be increased suspicion of neurogenic fever. Increased temperature in the post-injury period is associated with poor outcome. So for every 1 degree rise in body temperature, there is 30% increase in metabolic rate. It is important to establish the cause of hyperthermia as they need to be treated differently. The diagnosis of neurogenic fever is currently a diagnosis of exclusion. Hypothermia was thought to reduce intracranial pressure. However, it bears the risk, including coagulopathy, immunosuppression, and arrhythmia. So, Eurotham trial, which includes 3,235, demonstrated hypothermia to 32 to 35, worsen clinical outcome, increased mortality compared to standard care alone. The Polar Act did not show that prophylactic hypothermia improved outcome, but did increase the risk of complication. So initial target is the core temperature in the normal range. If core temperature should be measured with the oropharyngeal nasopharyngeal probe, active cooling measures are frequently required to achieve the norm. Mild hypothermia is the tier 3 therapy. Now, regarding infection, screen for infection and the treatment is indicated. Regarding active cooling, discuss appropriate method of cooling with medical team. To maintain normothermia and antipyretic, paracetamol and patient exposure. Pyrexia should be aggressively managed if passive measure is ineffective. Surface cooling pad. Shivering should be avoided as it increases the oxygen consumption. A tired approach to the shivering management is appropriate, like passive counter warming, active counter warming, increased sedation, and finally neuromuscular blockage. If inducing hypothermia, insulin resistance may develop, so monitor the blood glucose level and start appropriate insulin infusion. Then sympathetic storm, say dysautonomia referred to the sympathetic storming is exaggerated stress response that occur in 15 to 33% of patients. It occurs within the first 24 hours or up to 2 weeks. Signs and symptoms including posturing dysautonomia, hypertension, tachycardia, pupillary dilatation, diaphoresis, hyperthermia, tachypnea. The precise mechanism for the increasing activity of sympathetic nervous system is unknown, but is believed to be the stage of recovery. It is more common in patients with the diffuse axonal injury. In sympathetic storming, the feedback mechanism when parasympathetic nervous system dampen the effect of increased activity does not occur. Episode can be unprovoked with the signs and symptoms occurring within the second and can vary from episode to episode. Trigger that may precede the episode including suctioning, repositioning, environmental sensory stimulation or fever. It is important to identify trigger so measures can be taken to reduce the length of episode, lessen its intensity, and even about the episode. Careful assessment is needed as differential diagnosis include expanding lesion, edema, seizure, deep venous thrombosis, pulmonary embolus, malignant hyperthermia, central fever, drug or alcohol withdrawal. Medical management focuses on treating the signs and symptoms in order to reduce potential adverse effect of prolonged activity of sympathetic nervous system. Regarding medication, IV agent like fentanyl, morphine, midazolam, clonidine can be used for rapid control. Consider enteral propranolol for maintenance therapy. Propranolol may improve neurological outcome. Avoid beta blocker if patient is hypotensive and bradycardic. Avoid seizure. Seizure activity in the early post-traumatic phase following head injury may cause secondary brain damage as a result of increased metabolic demand reached intracranial pressure. There is evidence that prophylactic anti-epileptic drug reduces the early seizure, but this is not supported by reduction in the late seizure. Guidelines suggest prophylactic use of anti-epileptic drug for 1. The mass prophylaxis trial demonstrate if levetiracetam or phenytoin is more effective for prophylaxis. So levetiracetam, that is 500 mg IV twice daily, is current first line for prophylaxis, and phenytoin is the second line if levetiracetam is contraindicated. Alternative agents that can be used are carbamazepine and sodium valproate. Then regarding sedation. Sedation holidays, it is weaning treatment. Obtain accurate neurological examination must be balanced against potential harm of pausing sedation. The risk of secondary brain injury must have reduced to acceptable level. Then on timing of sedation holidays is difficult to achieve. So ICP monitor removal as the sedation holidays, the key factor guiding removal of advanced neuromonitoring is the risk window for secondary injury. So on timing of ICP monitor removal is also difficult to achieve. Heat maps are available to guide decision making. 72 hours of control ICP is almost universally accepted at suitable time point for consideration of monitor removal. Therapeutic intensity prior to ICP control and GCS motor score are strong influencers on decision over removal time. Brain oxygen monitor when used would usually be removed at same time as ICP groups. Regarding positioning, avoid venous congestion. There should be head up to 30-degree. Head and neck should be in the neutral position. Turn and reposition the patient with caution. jugular vein compression can be seen as an increase in mean ICP. Then increase in ICP waveform amplitude, mainly P2 and P3. The patient is unconscious and cervical spine needs clearance, follow unit protocol. Then about venous thromboembolism prophylaxis, mechanical thromboprophylaxis in all TBI patients unless otherwise contraindicated. Consider chemical thromboprophylaxis at low risk of bleeding. Consider from 24 hours of the admission. Consider chemical prophylaxis from 72 hours in patient at moderate risk of bleeding if CT appears stable. Use caution in starting chemical prophylaxis in patients at high risk of bleeding, including those where neurosurgical intervention performed within 72 hours. Consider IVC filter if bleeding risk preclude chemical prophylaxis for prolonged period. However, early prophylactic use of IVC filter is not associated with the reduced risk of symptomatic PE or death. Low molecular weight heparin may be superior to unfractionated weight heparin, and its use should be guided by anti-tenue factor assay. Now, regarding transfer, minimum monitoring when transferring patient like EEG, the ECG, and oxygen saturation, EtCO2, arterial BP, and IC. Consider ophthalmology review. If patient has facial injuries and there is suspicion that there may be eye damage and obvious eye damage, refer urgently to the ophthalmologist. Regarding nutrition, severe brain head injury patient are hypermetabolic and hypercatamic. Prescribe a high dose vitamin on admission. If any suspicion of chronic alcohol use, chronic malnutrition, followed by the regular enteral vitamin. So early enteral feeding within the 24-hour of admission. Patient should be fed to attain full caloric replacement by day 7. Monitor for refeeding syndrome. Then regarding blood glucose monitoring, try to maintain the blood glucose level between 140 to 180. Thank you.